hot topic of the Psychiatry and Narcology course, and today's topic is about organic psychosis, which are caused by a variety of somatic disorders, as well as epilepsy, and dementia is also in this topic, but we'll be talking about dementia on a separate video, not today. So let's start with organic disorders, so symptomatic mental disorders, and then we'll proceed to the epilepsy. Organic or symptomatic mental disorders is a very big group with a variety of illnesses and conditions. And usually when students start to learn this topic, they become lost in a variety of different symptoms and syndromes here. Not to mention that actually any somatic disorder which affects the nervous system has a potential to cause a mental disorder, a disorder of psyche, because psyche is the production of our nervous system. So what you need to remember is that all these disorders share the etiology in cerebral disease or brain injury, or for example other insult leading to the dysfunction of the brain. So there should be a direct impact on the nervous system here. The dysfunction should be can be primary if we are talking about direct impact, or secondary if we are talking about systemic diseases like metabolic changes in the body, endocrinopathies and stuff. So by the nosological principle, we can divide all these mental disorders into infection, exogenous, brain tumors, also somatogenous and endocrinopathies, vascular diseases, and atrophic diseases of the brain. So when we are talking about the dementia, usually we are talking about atrophic diseases of the brain, but some dementias can be caused by vascular disease, and we'll be talking about this. So all the exogenous on there can be divided into infectious disease, traumatic factors, and also ecologically unfavorable factors. Okay. When we are talking about psychic changes in people with somatic disorders, usually these changes may not be evident right away, because this is a production and functionality of our nervous system, but we are usually more aware of structural changes and like analysis changes, and not the behavior of the person. But any doctor, no matter what field they are working in, should be aware that their patients can develop certain psychopathological states, and should be at least knowledgeable enough in order to cope with these states themselves, or to call the appropriate specialist, for example, psychiatrist. It is a very common practice when a psychiatrist is called as a consultant into somatic wards in order to tell what is wrong with this pregnant woman, for example, what is wrong with this person after the injury or after the operation and stuff. Not to mention that before the operations, all patients should be consulted via the psychologist in order to be prepared for the operation. But that's the field of the medical psychology. Here we are talking about psychiatry mainly. Okay. So how can we suspect that this psychopathological state is most probably caused by some organic cause? There is a temporary relation between the development of the basic disease and the mental disorders which succeed the disease. There is also a reduction of mental disorder if the main illness is cured. And there is also absence of any data about other causes of mental disorders, because when we are talking about serious mental disorders, which are primarily coming from the dysfunction of the psyche, usually they have a congenital basis. Usually they have some genetic predisposition in them, and then these people will say that, for example, okay, I may have not well, maybe there are no schizophrenics in my family, for example, yes, but there is a lot of people with paranoid accentuations. There is a lot of people, for example, with weird beliefs. Usually it is incorrect to think that suddenly the psychiatric disorder just arises in the person, in their family, with previously no known cases of strange behaviors. No, usually these strange behaviors pile up. These states and these accentuations pile up, and only then we can get at least one member of the family who manifests as a psychotic. So it doesn't happen out of the blue. And usually I use this excuse to help patients, for example, who do not have mental diseases, but who suspect they have, and start to attribute normal phenomena of our psyche to different noxious factors and illnesses. And then I will try to explain them that, if you do not have any relatives with this strangeness in their behavior, with their anamnesis, like your collective family analysis of psychiatric disorders, it probably means that you do not have a disorder yourself. You won't be the first one in line, for sure. Okay. Clinical picture. Well, clinical picture of a disorder, mental disorder caused by some organic or somatic disorder is various. Is very various. I would say that you can take basically any psychopathological symptom and slap an organic before it, and you get a symptom you will see in an organic disorder. So, for example, in organically induced mental disorder, for example, organic catatonia, for example, organic hallucinosis, organic stupor, organic, I would say, organic delusional disorder, for example. Basically, in any of these cases, there may be any symptom. But there are some, I would say, common traits, common things which help you. I have already talked about the symptoms which help you to suspect that the reason is organic for this case. And there are some symptoms which may be common among certain groups of disorders. Overall, what I needed you to know that, for example, and I have mentioned this before, asthenic and neurotic syndrome is common among all the diseases, because you will get the weakness of your strength, you will get irritability, you will get this diminished attention and fatigue almost whenever you are ill with any illness. So if you will try to explain the clinical picture of a certain organically induced psychotic disorder, if you slap this syndrome, you wouldn't be wrong, because it is a very basic syndrome. But teachers are aware of this, and usually on exams this is not the only one syndrome you should name, but it helps. So you should know that there is always asthenia. What else? If we are talking about diminishment of breathing system, diminishment of the nourishing of the brain by blood vessels, there will be most probably depressive syndrome. Or if you are talking about also endocrinopathies which happen to reduce the rate of our metabolism, for example, hypothyroidism, there will be depression in such a person, because our organism just doesn't get enough energy to function, or should function much slower on the baseline level, like in the case of hypothyroidism. So here we are talking about depressive syndrome. So such people will get depressive syndrome induced organically. What else? If we are talking about the disorders of other disorders of breathing which cause, for example, the person to suffocate, disorders of the heart rate which cause pronounced tachycardia or pronounced bradycardia, which the person feels like different extrasystoles, etc. They will most likely cause anxiety. They will cause anxiety and fear, and there is such term called cardioneurosis, when the person is specifically focused on the idea that they may have a problem with their heart, and their fear being focused on this problem is only enhanced by their attention to it. Because physically, if we are feeling stressed, our breathing becomes faster and our heart rate becomes faster, so it is physically inducing us to feel these emotions. So once again, here we have phobic disorders and anxious disorders. What else? Important thing, you remember, and I have mentioned it, that there are disorders of consciousness, such as delirium, for example, monoid, but delirium mainly. They can be caused by intoxication. So any disorders which come with a lot of intoxications, tuberculosis, hepatitis, for example, different encephalopathies, comas, metabolic disorders, they can cause, and also oncology, they can cause delirium. So if you ask, for example, what is the clinical picture for psychosis on the basis of, for example, chronic hepatitis, they have intoxication, they will have changes of their consciousness, most likely deliriums, such thing. Okay, What else? What else? What else? Well, that's like the basic stuff, but now I'm going to go more in depth into different cases of these disorders. Okay, yeah, I have already mentioned asthenic disorder, neurotic disorders. There are also affective manifestations, so depressive syndrome, for example. There may be psychopathy-like. Psychopathy-like syndromes are more common among people with, I would say, with head traumas and with dementia. So with something progressively taking its toll on the nervous system, especially when the frontal lobe is impacted by this state, because the person loses the control over their impulsivity first and foremost, and their personality changes. Also, yeah, delusive states. We talked about this. Yeah, about tumors, that will be a whole another part of this lesson, because tumors are very important, and once again, the clinical picture very much depends on their localization, but I will be talking about it later. So let's not run too fast throughout the topic. Okay. Yeah, also psychogenic syndrome, well, basically it is defined by the organic factor it was caused by, and dementia. I have talked about this. Okay. Yeah, also you shouldn't forget that there is a certain psychogenic factor which can provoke the development of mental disorder, because I have already given you an example. A person who is afraid that something will be wrong with their heart, and they devote their attention towards the function of their heart, sooner or later they will find those symptoms they're looking for. And that's not organic case, but still, I was consulting a patient today who was suspecting that she has schizophrenia, and she was actively seeking out the symptoms of schizophrenia in order to get them. And I told her that of course you will get those symptoms because you are looking for them, but the very fact that you are looking for specific symptoms and you are able to find them is what differentiates you from the real person with the real disease, because the real schizophrenic usually doesn't have enough willful control over their attention in order to seek out these symptoms. They either do not recognize those as symptoms, or these symptoms happen to them involuntarily, and that's because that's a disease. It is chaotic, it is out of the control before you learn to control it. So yes, that's why that's why the psychogenic factor can be very important in these cases. You can cause yourself to have symptoms which you wouldn't have otherwise. This works more for the people with high suggestive levels, for example, with people with histrionic traits, also people with autism. It may work very, very well, but it depends on the kind of person you are talking to. Okay, so when we are talking about cardiovascular disease, which disease can cause mental disorders? Coronary disease, angina pectoris, myocardial infarction, arterial hypertension, and cardiophobia. When we are talking about myocardial infarction, we differentiate two periods. There is acute period and subacute one. And the disorders vary a little bit. So when we are talking about acute period, what we are scared of are a disturbed consciousness, because once again, there will be a certain intoxication, there will be disturbance in the blood supply to the brain. So there may be a variety of disorders from torpor to coma. Sometimes there will be delirious states, and there may be affective changes, mostly in anxiety, depression, and sometimes in motor excitement. So the things I have already mentioned to you. It's just that I mentioned some things out of the plan when they pop up in my mind, not to forget everything. Okay, so when we are talking about subacute period, here we will see hypochondriacal disorders, once again caused by this anxiety over the fact that I have had myocardial infarction once, maybe I'll have it once again, so the person becomes fixed on their body and on their health. Also, the anxiety and depression, which may change into euphoria with inadequate behavior of the patient, but that's just another side of the same coin here. And of course, asthenic symptoms, as usual. Arterial hypertension is much more prolonged in its effect on the psyche, because usually people pass through a lot of years before they get some pronounced symptoms. And I would say that this is very important because I have had this patient presented to me who was talking about having people talk to her through the TV. She was feeling that she was being watched, etc. So all the things she said were typical for schizophrenia. But what was out of the clinical picture? You haven't learned schizophrenia yet, but still, what you need to know, she was perfectly okay with her emotional expression. There were no pathology here. She was very vivid in her emotions, both towards others, so empathy was intact, and both towards herself. And there were no other symptoms apart from these delusional ideas and these hallucinations she had. And when I asked her, yeah, and also she was 46 years old, and she was a primary patient, so she wasn't hospitalized before. And schizophrenia usually develops in the 20s, so it's very unusual to see such disorder at this age, 46. So I have asked her what was her blood pressure, and she told me that her blood pressure was usually over 200, so she was hypertonic. And because of this, we can see that this hypertension took a toll on her nervous system, on her brain, and this was the cause of this schizophreniform disorder, while she wasn't schizophrenic actually. Okay. So in the initial stage of the arterial hypertension, the patients may have anxious, suspicious streaks with low mood, and their attention once again is fixed on their feelings. Sometimes they may ignore the disease, so they will be anosognostic. And when progressing, the Gastrointestinal syndrome intensifies. There may be memory disturbances because, once again, the blood vessels are impaired here. So basically, nervous system doesn't get enough nourishment, and so different neurons may even die because of this. There may be mood fluctuations, faint-heartedness, because the control over impulsivity fades away, and there will be a hypochondriacal fixation. I'm sorry, I don't get enough sleep these days. Okay, so there is also cardiophobia. I have already talked about this. So the person has vague uneasiness and anxiety, suspicions and fears which are connected with their health, and especially their cardiological health. And when we are talking about the disorder or the behavior, is when this fear starts to govern the actions of the person, and the person, for example, tries to restrict their own lifestyle beyond the point of it's being useful for them and healthy. For example, they do not leave their home at all because they're scared that they will get a heart attack, for example, in unexpected places, and nobody would help. So here we can see that this restriction goes too far. The person exhibits control in the area where the control is just too excessive, it is not needed. So that's when we are talking about the disorder. Okay. What else? Yeah, so about respiratory organs. So of course bronchial asthma, because I have told you that when people suffocate, they can develop a certain phobic ideas around this. And also chronic bronchitis. But here, when we're talking about chronic bronchitis, mostly it is connected with anxiety and depression, because once again, you are deprived from oxygen, from quality getting the oxygen in your blood, and that's why you will feel anxious and very depressed because you have no energy. Okay, so here is that. What else? Yeah, gastrointestinal pathology. Well, we are talking about peptic ulcers, and you should be actually worried about those as well, because this changes the intake of different bioavailability of different drugs if the person has an ulcer. So you may want to raise your doses if you know that this is justified. And apart from peptic ulcers, we also should know about hepatitis and cirrhosis. And here I have already talked about hepatitis and cirrhosis. Also, depressive syndrome will be also evident in hepatitis, because once again, the person just constantly loses their energy to this illness, they get intoxicated. And when we are talking about peptic ulcer, usually these people are very emotional, and they will be dissatisfied with a lot of things. They may be irritable. They may develop hypochondriacal, neurotic syndromes, and even psychopathy-like syndrome due to the extreme excitation of the nervous system. Well, nobody would be actually satisfied with their life if they constantly felt pain in their body, obviously. Okay, renal diseases. So another disease which can cause intoxications, once again delirial symptoms. Also, not only delirium, but also twilight states of consciousness. So psychotic types of the change of consciousness can happen, not only delirium, but also twilight states. Also, there may be organic mental syndrome or encephalopathy as a result of this intoxication. Dysphoria, different sleep disturbances is another interesting thing. So usually there is sleepiness at daytime and insomnia at night, and even hypnagogic hallucinations for such patients. So if you remember, hypnagogic hallucinations are the hallucinations we can see when we are trying to go to sleep, hence hypnagogic. Okay. Also, delirious omnitoid states can occur. So also oneroid oneroid syndrome can occur. Yeah, and dementia as well. What else? Okay, that's all. Yeah, also there may be hyperesthesia and irritable weakness, so neurasthenia may develop in patients with renal diseases. Okay, now about human and obstetric gynecological pathology. It is very interesting because we know that our mental disorders usually exacerbate throughout the crisis periods of our life. This includes puberty, and as well this includes pregnancy and delivery. So the whole period of pregnancy and delivery and postpartum period are very important in the case of mental health, and a lot of disorders may exacerbate at this time, as well as develop as a result of the change of the persons and as a result of the person's reaction to what is happening in their life. Because yes, 9 months you have been walking around with your baby in your belly, but you may not be psychologically prepared to have this baby and to raise them. And when you finally see that your baby has arrived and it's a living person which you should care about, and you are now embodied with a lot of responsibility for this. So for some people, this may be a crushing psychogenic factor. So people may develop, especially postpartum depressions, for example, even to the point when they try to kill themselves or the baby, because they cannot bear this responsibility. Not to mention that sometimes husbands are not able to give enough attention to this situation, and of course these women feel that they have lost their will and ability to live further this period. So what can happen? There may be reactive depressions, there may be anxiety, increased anxiety and hyperactivity prior to the delivery, obviously. Asthenia, also disturbance of consciousness, sometimes irrational behavior and excessive affectedness. Also, there may be dysgeusia when the person tries to consume foods which they normally wouldn't, because sometimes people with pregnancy may lack certain micro elements in their body and they try to substitute them. So, for example, they may eat chalk and such things. Also, psychosis caused by labor as well. And when we are talking about postpartum and postnatal mental disorders, the time period for these mental disorders is 1.5 months after delivery. If it is longer, then we are not talking about the psychosis caused by the delivery, but we are talking about the exacerbation of some underlying illness the person already had, but there was no enough stressors in order to open up this disorder. So, about postnatal mental disorders can include catatonic neuroid disorders, hallucinatory paranoid symptoms, and this can happen even in lactation period. So, it is very, very important. So, usually people in obstetric gynecological wards know about this situation, so they are prepared to tackle the case, for example, if the pregnant woman or the one who has already delivered, if they start to behave abnormally. The problem is, of course, with the choice of the medicaments, and we'll be talking about the treatment on the last lesson in this course, but I would say that all psychotropic drugs are assumed to be secreted in milk and to be influential on the fetus in one or another form. And it is usually very important for you to understand how to choose the doses and how to choose the type of the medication, because in the lighter case you cause damage to the child, in the worst case you kill both the child and the mother. So you should be very, very, very careful with this. Okay, dementia. So an overview of dementia is that there is diminishment of higher cortical functions such as memory, thinking, orientation, understanding yourself, comprehension, calculation, language, judgment, including control over impulsivity, and learning capacity. So these things are impaired in people with dementia. People with dementia can have both dementia and a psychosis developed on the top of this, because usually, since we are talking about organic disorders, and this is another thing you should understand, people who have already had an impact on their nervous system, there is a certain weakness and lessened resistance in this nervous system to different stressors. So people with dementia already have a higher rate to develop different mental disorders, because they already have this lesser resistance in them. So yes, the person with dementia can develop psychosis, and it is a very common thing. Even now, throughout the war, some of the most popular, I would say, requests are to help some kind of granny who started to behave very, very weirdly. Because, of course, right now, most of the problems exacerbate. But you need to understand that usually in dementia, the consciousness is not clouded. If it is clouded, we are talking about some form of psychosis. Okay, so I will be talking about Alzheimer's on another days. Yeah, I'll be talking about vascular dementia. So vascular dementia can develop as a result of the infection of the brain, including hypertensive cerebrovascular disease. Impacts can be small, but their effect accumulates, because we know that these neurons, well, rarely reproduce. It is possible to induce new connections, but it is very hard to do the older the person is. And when we are talking about infections, usually it is about old people. Okay. What can happen? Also, vascular dementia can be the result of cerebral atherosclerosis. That's why it is not such a good thing to have. So what can happen? We can observe, of course, neurosis-like syndromes, psychopathy-like, because I've told you, in dementia there is an impaired control over impulses, so psychopathy-like behavior. Also, the fact organic states, such as Psychogenic Syndrome and Korsakoff Syndrome. And if you remember, Korsakoff Syndrome is characterized by amnesias, retrograde, anteroretrograde, and also fixative amnesia and confabulations. Also, there may be psychosis, acute vascular psychosis, or in the form vascular psychosis. And when we are talking about that woman who suffered from hypertension and who presented schizophreniform psychosis, this was the actually endoform vascular psychosis. So it was caused by the vascular disorder, and it imitated an endogenic disorder. So endoform. That's why it is called like this. Also, when we are talking about dementia, we can remember also Pick's disease. So this dementia is progressive. It starts in the middle age, from 40 to 65, so a bit earlier than usually starts the Alzheimer's disease. They progress slowly. This disease progresses slowly, and there is impairment in intellect, memory, and language function. Then we can have apathic euphoric variants, and sometimes even extrapyramidal phenomena. Extrapyramidal phenomena are the changes in the body tonus, movement. Sometimes the person may not sit down for a very long time. They feel that they need to move all the time, and there may be forced movements of their facial muscles. So those are extrapyramidal phenomena. And there may be prevalence of emotional volitional disturbances, so basically neurotic disorders. And the most important thing is lack of spontaneousness. People with Pick disease become very indifferent and passive in their behavior. But actually they are able to move themselves voluntarily. It is just that they do not do. Also, dementia includes Fels-Yakov disease caused by prions, and this is usually at any age, depends on when the prion has entered the body of the person. The cause is subacute, and the person dies because of this disease within 2 years. When we're talking about Huntington's disease, this dementia usually is very slow in progression. So the person dies in 10 to 5 to 15 years. And it is a genetic disorder caused by the dominant gene. So that's what you need to know. Okay, so here is that. I needed to check what is written there in my messages. Okay, now also Parkinson's disease. Parkinson's disease can also cause dementia, not only problems with the movement. And if you remember, well, there are not particular symptoms of this dementia which differ from other dementias. But if you have remembered, I have mentioned that we should take into the account the way the person reacts to the disease. There was this actor called William Robbins, and he was diagnosed with Parkinson's disease. And if you remember, if you knew him, he was an actor. And after he was diagnosed, he fell into deep depression, and which resulted in him taking his own life. Even though his whole life he was starting in comedies, he was a very positive person overall. So unfortunately, he couldn't process the thought of him not being able to act while having this disease. Even though actually, since if you are an actor, you can be anyone. I think that, in my opinion, he would have found an exit out of this situation. He would have found roles which were written, for example, for the person with Parkinson's, so he would be able to continue. But he just couldn't bear this idea. He didn't see this exit, and he was afflicted by the depression, so unfortunately he took his own life. So this happened while he was still critical to his state. And when we're talking about dementia, usually people stay critical for a long time, but then unfortunately they are not able to assess their state anymore. So here is that. Now, also, when the person is affected with HIV and develops AIDS, we can also get dementia from this case. And usually there is a very pronounced disturbance of active attention. There may be neurosis-like symptoms and also psychotic ones. There may be antisocial tendencies. And there was this case. I have talked to the woman in hospice who was suffering from the last stage of AIDS. And she told me that when she was diagnosed, firstly, she became so angry and despaired that she went to all the salons of manicure she could find in the city, and she didn't warn the people working there that she had this diagnosis in order for them to cut her and to infect other people. While she was lying there in front of me on her deathbed, she deeply regretted this decision, this behavior. It was impulsive. It was just the despaired reaction on her disease, and she understood that it wasn't worth it. She didn't want to do this. She was feeling guilty for this, but unfortunately nothing could be done, and she was dying, and she died with this act and with these consequences of her decision. So as you can see, antisocial tendencies can be here because the person is just filled with anger and also shame and regret about everything when they are diagnosed with such grave diseases. Even though at the moment of now, I know that this disease is actually very, very well controlled. So it is not as dangerous as it was before. But for many people, it still sounds as a curse. And they don't want to live with this curse. Okay, so there may be depression, of course, suicidal thoughts, suicidal acts. There may be hypomanic and maniac states, which is another form of reaction, but a very acute one. This means that the person just cannot be at the depth of their depression, so they fall into the opposite side. There may be delusions of reference. For example, other people know that they have AIDS. Other people despise me for this. Those people know that they have AIDS and such stuff. Sometimes they may even think that they are persecuted because, well, if you had a lot of partners, of course, they would not like to be affiliated with you anymore. There was also another case, a very sad one. So one woman referred to the gynecologist with the complaint that she doesn't have orgasms, and when she was observed and there were a lot of different analyses taken, it was revealed that she had not only AIDS but also syphilis, trichomoniasis, also gonorrhea, and all the stuff you can imagine from the venereology. Okay, so her gynecologist told her that please tell your partners which you had for the last month that you have these diseases because they are very, very bad things to have. And she was like, well, I'm not notifying 52 people. I cannot even imagine how she managed to get so many partners, but yeah, now there are 52 young men. Some of them are women who are not aware that they have this disease. And the good thing is that syphilis usually emerges much earlier than other diseases, but that's horrible. So such stuff happens, unfortunately. Okay, so what else? Yeah, I have talked about this. Also, other diseases which can cause dementia. Epilepsy, lipidosis, hepatocellular degeneration, hypercalcemia, hypothyroidism, which is acquired, also multiple sclerosis, neurosyphilis, niacin deficiency, also polyarteritis nodosa, also systemic lupus, erythematosus, trypanosomiasis, even parasites can cause this disorder, and also vitamin B12 deficiency. Also about neurosyphilis, there is a pathognomical syndrome called Argyll-Robertson syndrome, when you see that there is different size on the both sides of the eyes of the person, and when you are trying to move the object closer and away from the person, you look at the movement of the pupils, how they adjust to the different distance. This doesn't happen, but the pupils react onto light, but they do not react onto the movement. So this is Argyll-Robertson syndrome, and this is a pathognomical symptom of the neurosyphilis. So when you see this, you know that the person has neurosyphilis. Luckily, right now, this disease is not as widespread because most people get cured from their syphilis early on, because this is the last stage of syphilis. But 50 or 60 years ago, it was very common. Okay, so here is that. Also, there may be organic amnestic syndrome, which is not induced by alcohol and psychoactive substances. It is about impairment of recent and remote memory, and the person is able to recall things, but they have reduced ability to learn new material and may be disoriented in time. Confabulations also can happen sometimes here. So it is called Korsakoff psychosis, non-alcoholic. Okay, so here it is. What else? Also, there may be delirium, not induced by alcohol and psychoactive substances. We have only delirium presented as a disorder. And I have talked about delirium in the previous lesson. Okay, what else? Also, organic dissociative disorder. This thing exists. Dissociative disorders are to do with the person being shut away from a certain function of the psyche. For example, the person may lose their sensitivity, or the person may lose their movement from one side of the body, but these losses do not correspond with usual disorders of the neurons, of the nerves. Okay. But the thing is that the difference from the neurotic dissociative disorder and this organic one is that this disorder happens after there was an organic provoking factor. For example, the person suffered from tumor, the person suffered from AIDS, for example, and they get this symptom. So there is once again a temporal consequence, temporal link between one and another. Also, there is emotionally labile or asthenic disorder, induced organically, so faint-heartedness, and mild cognitive disorder, when we cannot say that the person has dementia, but there is a certain disturbance and diminishment compared to the usual level of functionality of this person. And this was very common after COVID, for example, for a lot of people. They have noticed that they have diminished cognitive ability from 1 month till half of a year after the disease. Okay. Yeah, so also organic personality disorder, so psychopathy-like syndrome, in case of the person exhibits mostly personality changes. There is also post-encephalitic syndrome. So after encephalitis, there may be behavioral changes, and this disorder is reversible. And of course, we cannot forget post-concussional syndrome after the head trauma. Once again, there are different periods. There is acute period, subacute, and protracted period. And most of the times, when we are talking about this, we are dealing with the symptoms such as headache, dizziness, fatigue, irritability, difficulty in concentration, performing mental tasks, impairment of memory, insomnia, reduced tolerance to stress and emotional excitement, or alcohol abuse. When we are talking about acute period of head trauma, we will get disorders of consciousness, surely, because we need to have a head trauma with the loss of consciousness for this symptom, for this disorder. Also, senile and presenile age. I have already talked about people while being senile, losing their control over certain functions of their brain, because once again there is reduced resistance, there is reduced functionality due to the old age. And so there may be also neuroendocrine shifts caused by the climacteric period. There are structural changes in their systems, and the person this can also suffer socially, because they discontinue their usual occupational activity. They lose their usual social relations because kids are already adults, and like your granddaughters and grandsons do not want to see you and stuff such. So they become isolated because of death of their relatives. And it may sound very harsh to you as a young person to think that people may become depressed and they may be scared of death, but usually old people are not scared of death. They're actually very ready to have it. My grandmother, who is already 90 years old, she constantly tells us that she is okay with being dead. She has come to terms with this thought. And this is actually good, because people who are still scared of death at this age, well, that's a sad thing. It just makes things much more complicated for them in mental state if they become scared of death. Also, there is a decrease in the emotional background. They may not be able to care for themselves. There are scantier interests and the shift to the sphere of material and physical well-being. They may become anxious. And of course, they may develop psychosis on the base of this. So when we are talking about senile period, it is after 60 years of age. When we are talking about 45 to 60, it is presenile age. So usually functional psychosis of the old age involve involution of depression or melancholia, involution of paranoid, when the person just talks about that, for example, the neighbors are trying to steal my stuff and such, and this is the only favor that they get. So usually old people are not very active in their and are not very expensive in their paranoid ideas. Also, there are atrophic diseases, so dementias at this age. Okay. I have talked about the head traumas. I have talked about these brain injuries. And of course, yes, psychogenic syndrome can develop as a result of remote head traumas. Okay. Well, when we're talking about infections, once again, neurotic syndrome and disorders of consciousness because of intoxication, especially at the high temperatures. And sometimes there may be even convulsions because, once again, the person suffers from this intoxication. There may be also abulic or pathoabulic this syndrome, when the person just doesn't have energy and mood to do anything. Okay, so here is that. Also about the tumors. There is Only one symptom of the tumors which I know, which is pathognomical, is the olfactory hallucinations, which usually are pathognomical to the tumors of the temporal region. So when you get these symptoms from the patient and you do not have any other symptoms for other disorders, like there is only one thing, I can smell which don't exist, you may suspect that the person has a tumor in their brain. Also, the localization of the tumor highly affects the symptoms the person has. For example, if we are talking about the tumor in the left hemisphere, usually it is psychomotoric excitation and disturbances of consciousness, such as twilight disturbance of consciousness. If you are talking about the tumors which are located in the right hemisphere, mostly we are talking about stupors, catatonic disorders, and also neurotic disorders. So here is the polarity. The person may move without understanding what is happening, and the person may be involved in something internal and not move. So here is that. Also, apathy can be a common consequence of a tumor, fatigue, apathy, such things. What can give you the suspicions that this person may have a tumor is the evolution of the symptoms which follow the patterns of the structure of the nervous system. So, for example, today the person comes to you and they complain that they have, for example, depression, that they do not want to live, they feel fatigue all the time.